Hi, everyone. A very good afternoon. Thank you so much for joining us today. I'm here to talk about a very interesting topic. My name is Dr. Bindu Chebrolu. I'm an assistant professor of cardiology here at Houston Methodist Hospital. All right, let's see what we're going to talk about today, right? As I'm sure every one of us had to encounter it at least once, in our lives. All right, let's take a few seconds, I should say. And please, if you all can write down if you have ever had to encounter any type of artifact. So let's see. Question is, please write down if you have ever had to encounter any echo artifact in your life ever. Well, I'm sure you all have listed at least one artifact. So my goal today is to go over some of the basic artifacts we encounter on a daily basis and learn the mechanism and tips on avoiding them. Sadly, I don't have any disclosures. Now let's take a quick look at this video. Are all these balls moving in a circle? Let's see. Can you guess which way this idol is moving? Well, actually, these balls are actually moving in a straight line, if you see. I'm trying to get to the point that we do make a lot of assumptions about ultrasound, and it's not always clear when it comes to ultrasound artifacts, and knowing the application of ultrasound physics and understanding them is very important. Now, here are some of our objectives of our talk today. So identify some of the anatomical pitfalls, which are nothing but benign or normal anatomical structures, which we often encounter. Identify some of the ultrasound artifacts. Learn the principles of ultrasound physics behind these artifacts. Learn some of the tips on interpreting and avoiding these artifacts. And finally, get some tips and clues on differentiating a real versus a true artifact. Like, right, what is a real structure versus an artifact? I do have an ambitious agenda to cover, but our outline is going to simply include learning a little bit about ultrasound assumptions and points to remember, learning some of the anatomical pitfalls like we talked about, a little bit about thinking outside the box and details of 2D and color Doppler artifacts, a little bit about spectral Doppler artifacts, and also a little elaboration on 3D artifacts. Let's move on quickly to what are the ultrasound assumptions we do in life, right? So first of all, we always think that sound always travels in a straight line. Second, we think that sound directly travels to the reflector and comes back and creating a reflection only once. Third, sound travels in soft tissue at exactly 1540 meters per second. And we also assume that reflections arise only from the structure's position in the beam's main axis. And we also assume that the imaging plane is thin, and also think that strength of the reflection is related to the characteristics of the tissues creating the reflection. Like, why are we talking about this, right? Why is it important to us? First of all, always apply ultrasound physics when in doubt and think of basics of an artifact. Remember, why are we talking about this? Why do we have this topic, right? It can change clinical management, and it can actually be very pertinent in critical decision making. And it's also important to consider the fact that true anatomy is always visible in all the views, right? And finally, don't hesitate to admit when not sure. Consider further imaging if needed to be sure. And also remember, everything we visualize, we want to look at it in the third dimension as well. And that helps also in differentiating real versus artifactual structures. Let's move on to learning some of the anatomical pitfalls, right? Let's try and see if we can keep this interactive. All right, let me see who are the participants today. All right. If any takers, do you want to start with something? Any of these categories? I know we are in a virtual environment. I'm going to make this easier. Maybe I can start off with the right atrium. Let's see if some of our fellows are logged in to answer these questions. All right, let's take a quick look at these videos. I'm sure you can identify probably all of them. Right? The first one here is basically nothing but a eustachian valve, right? Or a Chiari network, which is actually a remnant of the right valve of the sinus venosus and is frequently associated with the presence of PFOs. The second one here is actually crista terminalis, which is basically a ridge extending from the SVC to the IVC. And this one here is actually a pacer wire, in the right atrium, which we often see. All right. Let's move on to the left atrium now. Again, these are very commonly noted on both transthoracic and TEs. This one here is actually a prominent Coumadin ridge, which we often see in TEs, but sometimes rarely we can see it on a transthoracic study as well. And we all know this is a benign finding. And very rarely we do see some prominent suture lines post-cardiac transplant, especially the older, transplant patients can have those prominent suture lines. Bottom line is, even if you're seeing some routine anatomical pitfalls, it's important to know some clinical relevant history. Let's move on to some other right-sided stuff, right? Let me see if anybody can guess this. Any of the fellows on, please take it. Unmute yourself if you want to say something. I'm sure you know which structure I'm pointing to. Well, that's basically a dilated coronary sinus. Is usually seen in cases with persistent left-sided SVC or in patients with elevated RAP. And left-sided SVC, as you all know, can be confirmed with a bubble study using a left-sided vein. What do you think is this one? So this one here is actually nothing but a prominent RV moderator band, which is usually more obviously seen when the RV is dilated. It is nothing but a prominent trabeculation of RV extending from the base of the anterior papillary muscle to the interventricular septum, and it usually contains the right bundle branch. And it's actually present in, it's a normal variant in most of the adults, but again, there are individual variations in thickness and shape. And finally, this video here, you see the echo density in the tricuspid annulus. In this one, it's basically dense annular calcification. As you see, the mitral annulus is also densely calcified. The other structure which usually we can see in the tricuspid annulus is prominent epicardial adipose tissue as well. All right, so let's move on to some other anatomical pitfalls. I know these are, interesting stuff we actually encounter on a daily basis, but we don't think about them quite often. All right, let's see if any of you can guess this one. Can you guess the odd one in this? Well, I'm sure if the audience are watching this, they can all guess that the fourth one here is the odd one, and it clearly shows the true apical aneurysm. But what's not abnormal about the others, right? So let's see here. So the first one here is actually nothing but a false apical LV tendon, which we all know as a benign finding. The second one here is actually an LV diverticulum, which we'll talk about in a little bit. The third one here is actually an apically inserted papillary muscle, as you can see. And this one, of course, is the large true apical aneurysm. So just a quick word about how to differentiate aneurysm versus pseudoaneurysm versus a diverticulum. And actually, LV aneurysm has a wide neck and is typically located in the apical or anterior wall. LV pseudoaneurysm, on the other hand, is actually it has a narrow neck with a wider base, and it's actually most often seen in posterior or inferior walls. LV diverticulum, on the other hand, actually is a benign structure. It's nothing but an outpouching of the LV that contains all the three myocardial layers and displays normal contraction. So LV diverticulum is distinguished from LV aneurysms because LV aneurysms usually have fibrous walls and exhibit paradoxical motion and usually do not have delayed enhancement on the cardiac MRI. How about some sinuses, right? We often see some pericardial sinuses, more like we also actually see them more often on TEEs. The transverse sinus is frequently located between the aorta and the pulmonary artery, and the oblique sinus actually is behind the left atrial appendage. And these actually are more prominently seen when there is fluid in the pericardial space. And sometimes it's very important because epicardial fat pad can be seen in the transverse sinus and also the oblique sinus, and they can resemble actually left atrial appendage thrombi. So it can be mistaken, if you actually notice it's just fat in the oblique sinus. So 3D TE actually is very helpful. And when you see something like this, obviously biplane imaging, looking at color Doppler flow of the left
actually are more prominently
and also normal atrial appendage emptying velocity for that. Now, finally, let's move on to some valvular stuff, right? How can we not talk about the mitral valve? This one here is actually very interesting. I'm not sure how many of you have paid attention. If you actually look at, a very good quality transthoracic study done on younger patients, you see these prominent kind of bright echo densities at the tips of the valvular leaflets. These are nothing but Albini nodules. These are caudal insertion points, actually, which are more prominent in young patients and are pretty, absolutely benign. The next one here is our aortic valve, right? How can we not talk about our famous Lambel's excrescence? I'm sure every fellow here has encountered it at least once in their life. These are nothing but the filiform fronds, which are seen on the aortic valvular leaflets. And the pathology here actually shows that they are filiform fronds. But what's important is also how do you differentiate them from the bulky fibroelastomas, right? So Lambel's are usually long and filiform and seen at the suture lines versus fibroelastomas are bulky and finger-like projections and can be pathological. How do we differentiate? I know it's not always easy. It depends on the clinical context. There are actually some rare cases of Lambel's excrescences causing embolic strokes and also, in fact, acute coronary syndromes from, kind of embolizing into the coronaries. And the approach to treatment has been variable. Some people are suggesting to treat with DAP for the first episode, versus if patients do have recurrent symptoms, actually they do recommend a trial of Coumadin as well. All right. Now, let's talk about the real ones, right? And we also see thinking outside the box. Let's see if all of you can guess this one. Do we have any fellows who want to take this? I see Sadhura, Smita. What do you think this one is? Right here, right next to the aortic arch. So this is actually nothing but the brachiocephalic vein and the aortic arch of the suprasternal view. And it's a completely benign, you see it on almost every echo if you do, if it's a good quality shot. This one here, what do you think? And you see it's a modified subcostal view. So that's nothing but a video of a loculated ascites, actually seen in an off-axis subcostal view. What is this one here? This, in fact, is a frequently encountered shadowing. If you see, there is that extrinsic kind of shadowing, which almost looks like it's extending beyond the, apical window. And that's nothing but, artifacts seen from breast implant, breast implants. And this one here is my favorite. What do you see? Large retrocardiac shadow there, retroatrial shadow. What do you think is that? That's nothing but actually hiatal hernia. And it can be confirmed by ingestion of a carbonated beverage. And you see how it's enhancing, the whole retrocardiac shadow. You see, I think we are hearing a little bit of a background noise. I'm going to try and see if I can mute everyone. All right, I think we took care of that. All right. Now let's see, now that we covered most of the essential anatomical pitfalls, so let's see if we can answer this bonus question. So what do you think is the next step when you see this image? And this is what we are talking about. Well, I'm sure all the sonographers, if they are on, will guess, definitely they would perform additional imaging, right? They would like at least a biplane image, add some color Doppler, and also 3D if feasible. But what it is, right? Let's see. Here's the TE of the image of this picture. And as you see, there is nothing on the aortic valve. This here is actually a slice artifact. This is a very classic example of an off-axis view causing an artifactual echo density on one of the valve leaflets. As you all pointed out, further assessment with color Doppler, biplane, 3D, all these are very helpful. So the key learning point here is when you see something, do not assume that it's always abnormal. Always, apply anatomical, landmarks and use it in the clinical context. So now starting with our 2D and color Doppler artifacts, let's talk about what are some of the principles of sound. So we need to know what happens when sound encounters an object, right? So what happens when sound strikes the specular interface? It can either get reflected with an angle of incidence being equal to the angle of reflection. And if the angle is 90 degrees, it can actually come back straight up. Or it can actually be transmitted right through it, depending on the propagation speed of the sound in that particular medium. Or it can be bent or refracted, depending on the speed of the sound in that particular medium which it encounters. Or finally, it can also be scattered, right? Scattered, on the other hand, is actually caused by poor reflectors and is actually increased with increasing frequency of the incident waves. And in fact, the backscatter is a portion which returns to the transducer, and it's what is useful for imaging. We're going to talk briefly about 2D or basic ultrasound artifacts, a little bit about color and spectral Doppler artifacts. Contrast artifacts, I think Dr. Zogby has elaborated beautifully in his contrast talk. And we'll also talk a little bit about 3D artifacts today. What are some of the 2D artifacts which we encounter? Reverberation, comet tail or ring down artifact, acoustic shadowing and enhancement, multipath or mirror image artifact, refraction or ghost image artifact, a side lobe artifact, a beam width artifact, and range ambiguity artifact. I'm sure you're all thinking these are some fancy names which we don't usually use on a daily basis. More than the name, it's the mechanism which we need to understand. And it's also important to know the tips on avoiding these artifacts. And that's why I'm trying to elaborate these further. All right, let's talk a little bit about reverberation or multipath artifact. It's nothing but production of false echoes due to repeated reflections between two interfaces, positioned parallel to the ultrasound beam's main axis, which ends up creating multiple equally spaced echoes. Let's see how it works, right? So when we transmit the sound, what happens? It hits the reflector, and then it bounces back, and then it creates an image. But what if this is a strong reflector, right? Now this whole process repeats again. Now it again hits the reflector, comes back, and then it creates a second image. And then this process can actually keep happening depending on how strong the reflector is, right? So this could be the real image. And actually, as you see, these are all the displaced or the reverberation artifacts. How do we really assess these, right? So first of all, remember, these artifacts are farther than the original reflector and are located actually at the multiples of the original distance between the reflectors. And they do not follow anatomical boundaries, right? Because these are all the reverberation artifacts and usually move in parallel with the reflector. And one tip for the fellows actually to remember the term step ladder pattern, or whenever they show you something in multiple kind of reverberation pathway, that's usually a reverberation artifact. How do you avoid this when you see them, right? First of all, change the gain and also change the imaging plane and alter the depth and make sure you're not actually encountering a strong reverberator in your field. Here are a few quick examples. The first one here is a step ladder artifact from a strong specular reflector. Second one here you see is actually the posterior pericardium, which is bright and is the strong reflector here. And it almost creates like an illusion of a pleural effusion. And if you pay attention, it's actually twice at the distance as the original reflector. This one here actually, as you see, is a artifactual dissection flap, and that's from a strongly reflective posterior left atrial wall. And another key important factor is the distance again, right? If you see, the artifact is usually twice the distance of the original reflector. Another one is actually a variant of the reverberation itself. It's called comet tail or ring down artifact, and it occurs when actually closely spaced reverberations merge, and it happens to be seen as a single hyperechoic line. And it frequently happens when there are two or more reflectors in a short distance, like prosthetic valves, like you see here, or very prominent aortic plaques. All right, let's quickly talk about acoustic shadowing artifacts, right? It's nothing but a hypoechoic or anechoic region extending downwards whenever you actually have a structure which has strong attenuation in between. So it usually occurs at interfaces where there are large acoustic mismatches. Like you see here, this is actually nothing but a strong, bioprosthesis, and the sewing ring here is the strong reflector, which is causing the streak of, acoustic shadowing. And this picture here again shows this is that acoustic enhancement, and this is that, acoustic shadowing. Acoustic enhancement is actually, on the other hand, a hyperechoic region beneath the tissue with abnormally low attenuation, and is actually caused by the low level of attenuation of the beam as it passes through the fluid relative to the greater attenuation of the beam in the adjacent tissue. If you see here, that's actually a fluid-filled cystic structure, and you see that acoustic enhancement beneath. We see this very often actually whenever we see a hepatic cyst or anything, even on an echo. All right, let's take a second and watch this clip here. Well, I wanted to show this in the context of a mirror image artifact, which is nothing but a reverberation artifact noted at an angle, right? The clue here is that the artifact is always deeper and it actually moves with the reflector. Let's look at a couple of examples here, right? So this one here is actually a parasternal long axis image. And you see here, it's almost there's duplication of the mitral apparatus. And that's nothing but mirror image artifact, right? And as you see, this thing is actually moving with the mitral apparatus. Here's another example, and that this shows that it can also happen when there's color as well. And if you see, this is nothing but color flow Doppler in the descending aorta, which is duplicated. Let's see if you can guess this one now. What do you think this is? Is it congenital aortic valvular duplication, aortic pseudoaneurysm? See, there's that extra. Any takers? Any fellows who want to unmute? Well, this is actually, I know you probably guessed it's an artifact. It's a ghost image or refraction artifact. So let's see, what is it, right? It's actually the change of the sound direction when passing from one medium to another. It's basically nothing but a side double image, but it's actually happening at an angle of the original reflector. And let's see if we can guess this example. Which one do you think is an artifact? I'll give you some time to look at the images. Well, none of these. Case A is actually a case of a retained guide wire in the descending aorta, versus case B is in fact an unfortunate scenario when the pacer was placed in the LV by mistake, secondary to access issues, and you can clearly see the pacer wire coursing through the aorta into the LV. This again, I just wanted to show you to reiterate the relevance of clinical history. Don't forget, everything you see is again not an artifact as well. You want to put it in the right clinical context. All right, now talking about side lobe artifacts. Again, remember, ultrasound beam, is capable of generating an image when these signals encounter strong reflectors. It can be out of the plane, and machine can actually, artifactually place it in the same kind of range. And for example, here, if you see, this is actually a linear arc-like side lobe artifact by the presence of a defibrillator wire. So it almost looks like the wire is coursing across the septum, but in fact, it's just an artifact, a side lobe artifact. And again, biplane imaging, and looking at other views can also be helpful clues in this case. And color Doppler will also be very helpful. This one here, again, is actually a side lobe artifact from a calcified sinotubular junction, mimicking an aortic dissection. This again can be avoided by decreasing gain, adding color, and also considering biplane imaging. And again, we actually see this one quite often. And this is nothing but actually a side lobe artifact from a dilated aorta. And we actually see this very commonly, and it's actually nothing but an elevational plane artifact. Let's move on to another question. What do you do when you see this one? And let me point to what I'm talking about. Well, I'm sure if I ask any of the sonographers who are watching this, what do you do with this? Definitely changing the imaging depth and altering the transducer location. So before you come up with anything, we need to further attempt to kind of delineate what we are looking at. So we guessed it, it's an artifact probably, but what is the artifact? It's actually called range ambiguity artifact. It actually happens when two transmit events occur at the same time. And if you see, they often appear as floating images. And if you, even in this view, even on the color, you can see that this particular structure almost looks like it's floating. So changing the angle and the depth actually helps reveal the reflector which is causing this. And finally, some of the interpretation clues as to how do we differentiate a real from an artifactual structure. So real structures usually have distinct edges, versus artifacts usually lack well-demarcated borders. Real structures always have independent motion and concur with the cardiac cycle. Artifacts usually don't have independent motion and usually move with the real reflector. And again, real structures are real, right? So they are attached to the other structures, they follow anatomical boundaries, versus artifacts do not have that clearly. And again, real structures are real, so you have to see them in multiple views in multiple depths, versus artifacts are actually not seen in every view or every depth. So again, remember in real life, always use color Doppler, alter the depth, and think about a logical explanation of what you're looking at as well. So moving on quickly to some of the color Doppler artifacts. Again, remember all the 2D artifacts we see can also be seen on color Doppler. And very important point to understand importance of color gain, right? And we'll discuss that in a little bit. A little bit about ghosting and aliasing related artifacts too. Here's one example. This is nothing but a reverberation artifact of color flow in the aorta. This one here is actually a mirror image artifact of color in the abdominal aorta. This one here is actually a refraction artifact, and you see the duplication of the vessel. And this one here, is again actually a ghosting artifact, which actually where there is a strong reflector within the field, it causes dispersion of the color signal, causing a band of bright colors, which is seen throughout the entire image sector. What do you think is the problem here? You see two images, or videos, I should say. And if you clearly see, definitely Doppler gain settings, right? So imagine, you can actually miss valuable clinical information if the gain settings are not obvious. We always recommend color Doppler gain should be increased to a level at which the background speckling occurs, and then decreased just so that it's optimal to identify the color flow. And some additional artifacts again are twinkling artifacts, which you can see as alternating colors and Doppler signal behind a reflective object. And then this one here is actually a flash artifact or a pseudo flow. It's mainly caused by soft tissue motion. And this one here is actually an ECOS catheter interference on color Doppler. Moving on quickly to a spectral Doppler artifacts. Again, whatever we see on color Doppler can also happen. We have Doppler gain related problems, beam width artifacts, device related artifacts, aliasing, spectral mirroring, blossoming and blooming, and wall filter saturation related artifacts. So Doppler gain, again, we don't want to delve into the details, but it's very important because undergaining can result in missing information, and overgaining can actually cause overestimation of velocities and gradients. As you see, an optimal Doppler gain should demonstrate that smooth spectral profile. Beam width artifact, then you have a large sample volume so that you're actually capturing multiple jets. That's another problem because look at this one here. So the mitral inflow is actually the aortic regurgitation signal is interfering. So, and you want to avoid that in clinical situations. This one here is device-related artifacts. Again, I'm sure you've encountered this, very often when you're doing LVAD devices and impeller-related devices. And then we have spectral mirroring or crosstalk, which is nothing but actually duplication of signals on both the sides of the baseline, creating the directional ambiguity. In such cases, look for the symmetry of the highest amplitude signals and use the brighter signals, right? This one here is nothing but a blossoming artifact where the spectral profile itself is widened because of increased color gain. And wall filter saturation actually is very important in clinical, world too, because when you're actually doing diastology or myocardial, tissue velocities, this is very important. You need to have appropriate wall filter saturation. Now, this one is a favorite artifact of mine, or I shouldn't even say if this is really an artifact or not. This is actually the double envelope pattern, or the, which we often see in patients when we are doing TEEs, and this is actually a real case where we had this. And, and if you see, actually, it's just from the strong, reflective back wall of the left atrium. And this is almost actually, Rebecca Hahn recently explained this very well on Twitter, where she actually, demonstrated the duplication of this artifact when the color Doppler gain was actually doubled. And actually they showed that it was clearly, duplicated even on normal mitral valves when they actually increase the color gain signals. So bottom line, when you see something like this, use the denser velocity or the modal artifact. So use the inner one, which is actually more reflective of the true one. And also, whenever you encounter this on TEEs, try to reduce the gain, alter the imaging plane so that you are avoiding the back, the reflection from the back wall. All right, finally, moving on to some of the 3D artifacts, including reverberations, shadowing, and we have, again, the same 2D related problems. Stitching artifacts are more common on 3D because, as you know, we do actually include more than one volume data. And then again, dropout artifacts, blurring artifacts, and blooming artifacts are something which we typically see. Here's an example of an acoustic shadowing you see, enhancement actually, sorry, you see on 3D. This is a blooming artifact, and this is a dropout artifact. Actually, we actually quite often see this, and we almost, can mistake it to be, a stuck or non-functional leaflet. This here is a stitching artifact, as you see. This is a multi-beat acquisition, and this here is a railroad artifact from the catheter. All right. So the last couple of bonus questions, I should say. Well, what do you think is this one? This one is actually called slice thickness or elevational artifact, almost mimicking a VSD, right? And if you see, it's actually the PR from a different elevation, which you're seeing on the parasternal long axis image. Very important artifact, actually. We've seen this quite often in our lab. What do you think, fellows? Why don't we see the ball cage prosthesis? I probably have to give you, I don't think, we've seen this in the recent times. But bottom line is, it's velocity error artifact. It's the slow and smooth motion, from the ball and cage prosthesis, which is actually not registering through the ultrasound. This one here is actually a special case, and if you see, you see the native mitral leaflets actually preserved here. So you see the bioprosthesis, but and the native mitral leaflets actually preserved. And that's one of Dr. Lowry's amazing case. All right, finally, so I do want to conclude saying always remember common sources of error and misinterpretation. True anatomy is always visible, and explain based on principles of ultrasound physics. And finally, know key points on how to avoid these artifacts, right? And stay tuned, we do have ASC guidelines coming up on this topic as well. I hope you don't feel like this. This is all I have for first, folks. We're going to have Mohammed Pasha taking us on a tour with the CT and CMR world. So stay tuned. And we can reserve any questions to the end if you all have, and I'll be happy to answer.
Hello, everyone, and thank you for joining us on the Multi-Modality Imaging Conference for today. My name is Mohammed Chamsi-Pasha, and I'm going to walk you through cardiac CT and cardiac MR artifacts as it pertains to this lecture. When we talk about artifacts, and I hope by now you all have seen probably this cartoon before, are these moving objects, or is basically this is an illusion to the eyes that is making us see those circles moving? The matter of fact is that these are all stationary. And let me start first with the first imaging modality, which is cardiac CT in this presentation. And really kind of the first and one of the problems we encounter in cardiac CT is really motion or blurring artifact. And this actually can occur either because the heart moves, which is cardiac, or because the coronary vessels are constantly moving during the cardiac cycle. That can occur in people who have irregular heart rates, say fibrillation, or people who have arrhythmias like premature ventricular complexes or PACs. The other type of motion that can occur during cardiac CT imaging is respiratory motion artifact. And typically in cardiac CT, the images are acquired during diastasis, which is basically mid to late diastole. And this is the period in the cardiac cycle that has the least motion from a cardiac and a coronary standpoint. And obviously, because of our limited temporal resolution on cardiac CT, we definitely need to administer beta blockers in order to prolong this diastolic filling period. And all of these cardiac or coronary CT images are acquired with a breath hold. One of the most common methods of acquiring CT images is using what we call a prospective ECG gating. So this is actually the classic step and shoot by which we actually acquire a set of images through the Z-axis across the cardiac field of view. the table moves, and then we acquire another set of images, the table moves, and then a third set of image, and then all these slices are stitched together to generate an image. So we do know basically the coronary arteries, they basically have different velocities through the cardiac cycles. And as you appreciate that the right coronary artery has the most or the fastest motion among all the coronary arteries. And that's why typically people who have slow heart rates, we try to image them during the diastasis, which is this 70 to 80% of the cardiac phase, where you can appreciate all the coronary arteries, they have the least coronary motion. But in people who have faster heart rates, we actually have noticed that there is also a period during the isovolemic relaxation time, typically between the 30 to 40% phase, where the coronaries are not as motiony in people with fast or irregular heart rate. So this is the end product. We really wanted to get a motionless coronary artery whenever we are assessing and acquiring those images. This is actually a classic case of a right coronary artery. This is an axial stack. We see here on the arrow, the right coronary artery, and we have this winging appearance or almost what creates a shadow artifact. And that's actually typically what occurs when the right coronary artery is out of phase because of motion during this prospective acquisition. This is a curved planar reformat of the right coronary artery. And what we notice here is basically when we acquire data at 450 milliseconds of the RR interval, which is basically very close to the atrial kick, we see this motion in the right coronary artery, while in this same patient, if you actually acquire data during the isovolemic relaxation time, typically around 300 to 400 milliseconds, so a little over the T wave after the aortic valve closes and before the mitral valve opens, we can see how now this segment is actually quite interpretable, and we are able to accurately assess for any luminal stenosis, while this one, the motion artifact, was severe enough that it really renders this segment interpretable for stenosis. This is actually what it looks like on a curved planar reformat. The motion artifact, you see this break in the vessel from the proximal to the mid or right coronary artery. This is the 3D volume rendered image, and this is the curved planar reformat showing this artery out of phase because of motion. Now, when we talk about cardiac motion artifact, which basically can be seen with arrhythmias, notice how you have this double shadow across the cardiac silhouette. Look at this LV, how it has a almost like kind of a double border. You can also look at the interatrial septum, the pulmonary artery, everything. It almost looks like there is multiple shadows across this area, which is the cardiac field of view. And when you notice here on these sagittal images, you almost have like those break in lines and basically shadows that are occurring over multiple parts of the heart. You can also notice this here in the left atrial wall. And the reason behind this basically is because the patient was in atrial flutter. And basically this led to the heart being out of phase from the variable RR interval, that there is actually constant cardiac motion during our prospective image acquisition in this case. We've known basically from the old generation cardiac CT scanners, the 64 detectors, that basically you need to acquire images over multiple heartbeats, and then these images are stitched together. So you acquire the first volume, which is 3 to 4 centimeters, and then after the second RR interval, you add on extra volume, and at the end, you actually end up stitching those images together in order to create a full cardiac field of view. But what sometimes happens is whenever I'm trying to stitch those images together, I can develop this misregistration or step artifact. And what you notice here in this right coronary artery on this axial orientation is that you almost have this blurriness of the proximal segment, and it almost appears that the artery has jumped out of phase. And that's typically what we see on this curved planar reformat, is this break in the line of the segment. It almost appears that the artery from the proximal to the mid, they're basically, whenever they were registered, they were not aligned. So you have this misalignment or misregistration or step artifact, typically what we see in the cases of prospectively gated images. So whenever you actually see those step artifacts, and you can actually see multiple ladder steps artifacts in this case, really one of the solutions that eliminates this problem is using the wide coverage detectors, or what we call the volumetric scanners. So and these basically have very wide z-axis coverage, by which with a single heartbeat, you're able to acquire the whole data without the need for stitching or acquiring data over multiple periods of the cardiac cycles. The other thing is the high-pitch spiral scanning mode, which Siemens has, and it's called the Flash. And this is also provides you with a single heartbeat acquisition and eliminates those step artifact. This is basically a case for a breathing motion artifact. We typically look on the sagittal views, and you can see there is a break in the line of the anterior sternum. And this actually affected this segment where you can actually see very suboptimal contrast enhancement in this proximal vessel, more likely because of a breathing motion artifact that renders this segment really suboptimal for diagnostic assessment of luminal stenosis. So really, it's very important, and our texts know this, that the patients have to practice breath holding, whether end inspiration or end expiration. And then we do know that the single beat acquisition modes, like the flash or the high pitch scanning, is really going to be the fastest in image acquisition. So if you have a volumetric scanner, like the Toshiba or the GE Revolution, will give you a single beat acquisition. If you have a Siemens scanner with a dual source using this high pitch mode, will be the fastest in order to acquire images without the need for a long breath hold. Here, what we notice basically is this multiple ladder step artifact, and this is actually from a patient who has had severe inability to hold their breath. Streak artifacts, basically the reason why they occur, because as we all know that the low energy X-rays, they tend to get attenuated during the CT acquisition, and the resultant X-ray beam is really going to be hardened with a higher weighted average of these pixels. So we do know that metallic objects like clips, wires, or stents, calcium, which also has the same concept, or regions with high contrast density will actually cause these streak artifacts. And other terms people use is beam hardening or blooming artifact. So you can see this actually a case of a proximal left anterior descending stent, and you can actually notice that these energies are being attenuated, and almost they create what we call this beam hardening or low density background in the middle of this stent, which actually might render the diagnostic accuracy for assessing stent patency less. Having said that, we actually have now sharp reconstruction filters on CT that's able to decrease this artifact in the middle of the stent, and now we can see a much better visualization of the stent and the contrast with less beam hardening artifact. This is a case of a patient who has a mechanical mitral valve, and we can see right at the surgical ring that you have those streak artifacts from the same concept of low energy X-rays being attenuated. And another case here where you see the pacemaker lead artifacts is also creating those streaks or blooming artifact. And you can actually also see here the coronary sinus lead is causing the same artifact across the neighboring structures. This is with contrast, and this is without contrast. You see the same magnitude of artifact. Blooming artifact actually which is also can occur in the setting of severe calcification of coronary arteries, and this is really kind of the Achilles heel of cardiac CT imaging, because we do know that these calcified densities, through the concept of partial volume averaging, they will actually affect and will overestimate the stenosis severity. So one slide about what partial volume averaging is. We do know that tissues that have different properties that are really contained in the same imaged voxel, they are going to have a weighted average of all the attenuation of these tissue properties within that voxel. And we can notice here actually that the different densities, like here the orange as well as the dark purple, you can notice that all these different densities, they will actually produce what we call this light purple, which is the volume average. And that basically occurs because of the inherent spatial resolution of CT, but at the same time, the blooming density of tissues that have a much higher attenuation than others. So it actually creates this bloom across the region of interest. One of the other artifacts that we also can see sometimes is what we call the CT noise. So we see all this basically noise in the background with a very low signal to noise ratio. And we can actually, this is typically attributed to low photon counts, because actually you don't have enough energy penetrating through the patient's body, typically seen in obese people. And really the increasing the tube voltage or the current will actually eliminate this noise. You can actually notice how this area here is much smoother and less noisy, so you have a much better signal-to-noise ratio. Increasing the slice thickness will help reduce the noise, but at the expense of reducing the spatial resolution, and then using soft reconstruction filters can also help eliminate some of that. Moving on to basically imaging artifacts in cardiac MRI. And really the main categories for cardiac MRI artifacts are going to be motion, either because of the patient moving or because of respiration, patient not holding their breath. ECG gating artifacts can occur in people with irregular heart rates or rhythms, or people with arrhythmias. Physiological artifacts can be either flow or motion mediated. Hardware artifacts, but we also have some inherent physical artifacts that can occur inside the scanner, either people who have metal, the chemical shift artifact, which is in the layer between fat and water, or susceptibility artifacts. And we're also going to touch base about the phase wrap artifact. These are one of the two best resources for MRI imaging artifacts. I would like to make you aware of these resources because they're great teaching files in order to learn more about the tips and tricks of those artifacts, how to recognize, and also how to eliminate. So this is actually a classic case of a short axis cine image using SSFP sequence. And we can see here that there is a blurriness across the entire field of view. And the reason behind that, you can see actually the mosaic or the blurriness in the lungs, the blurriness in the liver. So this is actually a patient who's having breathing artifact, inability to hold their breath, causing basically this excessive artifact. And really one of the solutions during those CMR gated acquisitions is basically to try to minimize this breath holding sequence. You can either reduce the case space lines, which will affect your resolution, or you can increase the data lines per the cardiac cycle. And last but not least, instead of using this retrospective segmented image where the images are acquired over multiple cardiac cycles, you can use a real-time acquisition, which basically can be acquired with a much shorter breath hold or even with free breathing. Gating artifacts, we do know that cardiac MRI data is usually acquired in a segmented fashion, meaning that we actually fill per RR interval multiple lines of data over multiple cardiac cycles. And the most common cardiac gating we have is the retrospective in the absence of irregular heart rhythm or arrhythmias. So this is typically what we see. We actually separate through bins or cardiac phases between the RR interval, and typically we actually acquire lines of data in each segment, and that basically allows us to acquire images over multiple cardiac cycles, as we can see here, by filling all these lines of data, typically within 20 to 25 phases is what we acquire in order to maximize our temporal resolution around 30 milliseconds. The difference between prospective versus retrospective gating, we can see here sometimes when we trigger over the R wave, we got a trigger delay, and then we acquire the data in a prospective fashion, and then we have to stop before the next QRS in order for the other impulse to trigger, versus the retrospective gating where there is really no interruption of the sampling and filling those case space lines. And typically we reserve actually that in people with arrhythmia. So we can actually see here the patient has excessive blurriness in his cardiac image on this 3-chamber view. And the reason behind that, because the patient basically was having irregular heart rates and rhythms in this case, and that basically affects my segmented acquisitions whenever I use my retrospective gating. But one of the other solutions in order to try to eliminate this blurriness that we see is to kind of go over prospectively gated acquisitions. This is typically used in people with atrial fibrillation, because although the diastolic filling periods are going to be variable, usually their systolic ejection periods are going to be constant. And this actually, although will actually omit the diastolic image because of the nature of the prospective gating, having to stop before the beginning of the QRS, it does actually improve your signal to noise ratio. And studies have shown that it actually does correlate with other modalities for LV function assessment. When we talk about the phase wrap or the aliasing artifacts, by definition, when parts of the body are outside the field of view, they get wrapped around to the opposite side of the image. And typically this occurs when our field of view is smaller than the spatial extent of all these radio frequency pulse excitations. And some of the solutions we have is we can either maximize our field of view, or we can actually oversample the phase encoding direction and or increasing the phase encoding step. So typically what you notice over here is on this 3-chamber RV long axis view, you can see actually here that the patient's arm is actually wrapping over this image. And the reason behind that, because our original field of view was actually smaller, especially in this phase encoding direction, which was from right to left. Now, it's also important to recognize those wrap artifacts, because on the late gadolinium enhancement imaging, so these are the scar imaging at the short axis, LV apex, you can actually, they can introduce a false positive lines. And the wrap actually, as we can see here, kind of it actually affecting the image quality. And if it's wrapping over the image, it can actually introduce a high signal intensity, as we can see here in the apical septum. One of the common sequences we use basically for cardiac imaging is the steady state free precession, and banding artifacts can actually occur. Usually they occur because this sequence really requires a very homogeneous magnetic field. And whenever we have significant dephasing of these proton spins during a single repetition time pulse sequence, that's actually when we see those. And it's really more common in the 3 Tesla rather than 1.5 Tesla. The higher the magnetic field, the more likely that you will have dephasing, and typically in areas of the significant field inhomogeneity. Typically, we actually adjust and use our shimming coils in order to cause more homogeneity within the magnetic field, and sometimes you can actually lower the repetition time to minimize some of this artifact. So this is actually typically what you see is those dark banding artifacts. Thankfully, it's not affecting the image quality in this patient, but that's actually very commonly seen in SSFP sequences. So here's a short axis using SSFP sequence across the aortic valve. And actually what we notice, actually there is a significant artifact, which is basically creating this, what we call a pulsatile flow artifact. And this usually occurs as we see here, the patient who has a bicuspid aortic valve because of the flow disturbance. And then when I change my sequence from an SSFP to a spoiled gradient echo, now I'm much able to appreciate the cuspidity, which is a bicuspid valve with a fusion of the right and left cusps, and actually much less magnetic field inhomogeneity compared to what I had with the SSFP sequence. And this actually is really kind of key in order to minimize this artifact. Some of the other ways in order to resolve these flow artifacts is that you can also use a shorter or reduce your repetition time. If you increase the bandwidth frequency of the sampled images can also help, along with decreasing the number of the case space lines or the segments can also minimize this flow artifact. This is actually a patient who has, these are the short axis, the aortic valve. You can see here the pulmonary veins coming in, and these signal voids or signal loss are usually flow related from the pulmonary veins entering into the left atrium. This is actually another shading artifacts that we actually are seeing here in a patient who is in a 3 Tesla. And these actually shading or band artifacts usually occur whenever a patient is in a larger or a much stronger magnetic field like the 3 Tesla versus the 1.5 Tesla. One of the artifacts that we also see during the stress perfusion myocardial imaging is actually this dark rim, or what we call the Gibbs artifact. And one of the theories behind that is sometimes you'll have a partial volume averaging between these two adjacent pixel intensities. The contrast load can also introduce some susceptibility effect, causing this signal loss. The cardiac motion has also been proposed. And typically, and also when we undersample these during our acquisition line can also lead to this, especially at the first pass perfusion. And typically, it shouldn't last more than 3 to 5 cardiac cycles. And that's really kind of what the area that you're seeing, this 1 pixel intensity. And here we're talking about a spatial resolution or pixel size in the magnitude of 1 to 1.5 millimeter. And it really does not last more than 3 to 5 cardiac cycles. Ion, which basically is a super paramagnetic element, will actually create a significant off-resonance artifact and will introduce a lot of magnetic field inhomogeneity, as we can see basically in this short axis image in a patient who has excessive cardiac and iron overload. This is a patient with a sternotomy wires, and these are the metal artifacts, which basically they cause susceptibility artifacts because of the loss of the protons. And then you also can get this pacemaker radiofrequency artifacts, and this is actually typically occurring in the slice encoding gradient. And you can see actually, thankfully, it's not affecting the image quality of the cardiac. You're still able to assess the borders, but be aware about these pacemaker artifacts that basically can be introduced in the magnetic field. And typically we reserve these pacemaker cases to 1.5 Tesla rather than 3 Tesla. Also, look at basically the ghosting artifacts that can actually introduce a false positive late gadolinium enhancement. So you got one artifact over here, you got another ghost artifact over here. And these basically, usually whenever they are related to the ECG, they'll only affect the cavity. But whenever you have ghosting from the adipose tissue, this is typically in people who are not able to hold their breath. So here, when it's related to the cavity, it's most likely that you have an arrhythmia issue. And here, when it's kind of arising from the adipose tissue, it's typically ghosting artifact because of poor breath hold. The arrhythmia artifacts also becomes important. So notice actually here a patient who has an arrhythmia and we're acquiring diastolic images every cardiac cycle, you can actually see that there is actually a loss of signal and basically what appears to be an artifact in this patient. While here, when we start to acquire data every other cardiac cycle, we've actually decreased and minimized our inhomogeneity and inconsistencies. And the reason behind that, because we're filling the case-based lines here at a much irregular RR interval, while here we're kind of more optimizing our imaging acquisition to count for these different RR intervals. When we talk about the late gadolinium enhancement sequence, we typically try to image the heart when it reaches the nulling point. And basically, we can notice that if I have a different inversion time, so the shorter the inversion time, the myocardium will be below the baseline. It will have a brighter signal. And it's really important to select the proper nulling time so that you don't call this scar while it's actually a normal myocardium that has not fully recovered yet. And actually, imaging should be acquired at the nulling time point of 0 for the myocardium to cross the 0 line. The chemical shift artifact occurs because of hydrogen protons in the water and fat. They typically have different precession frequencies by 3.5 particles per million. And what can happen is that along the frequency encoding direction, because these fat and water spins, they're going to have different frequencies, although they could be in the same position, you can actually have a signal loss by which the signals from the fat and water are going to be shifted or they cancel each other. And this is typically what we see here, this black artifact in this patient who has a pericardial fluid or a pericardial effusion, and then there is also basically the epicardial fat. So this fat water the fat water space can actually create this chemical shift or a cancellation artifact because of that. So with that, I really would like to kind of emphasize the take-home message that the knowledge about the appearances of artifacts is really essential to avoid misinterpretation and be aware of the available methods for lessening the severity of these artifacts, or even better, eliminating them. Thank you so much for joining in, and looking forward to meeting you all soon.
Forward to see you next week again. Take care.